hear my all in all slip away. I would walk in the house every day and I'd say, Dad, you're still my favoriteest person in this whole wide world. And his answer to me was always, you're still my little girl. So you all know I was devastated when he passed. But my phone rang one afternoon for the second time and asked me to come in and get tested. It was his cardiologist. And I thought to myself, if she took the time to remember her patient's daughter, it was time for me to get serious about getting tested about this condition and see what was going on with me as well. So she walked me through the condition. After I got tested and tested positive, and I have to let you all know that these genes are strong. I'm not surprised I tested positive because I look like my dad, I act like him, and sometimes I think like him. So the question is, why wouldn't I have amyloidosis just like him? So she walked me through the condition and we prepared for treatment and so forth, and she explained everything. At that point, I started attending webinars and seminars on a regular basis to understand this condition, how it develops, how I got it. And the key word here is genetics and heredity. So I realized at this point I wanted to follow my passion in my career because I realized that having amyloidosis helped me understand that people need help and people need help living quality lives. So I went back to school and got certified as a health and wellness coach. So not only can I understand the health concerns, but I can also help people through their journey with this condition. And as my dad, our legacy isn't this condition. Our legacy is to learn how to keep fighting.
Yes, absolutely. Oh my goodness. Thank you for sharing not only about your journey, but about your dad's journey and kind of where it's taken you and your legacy. And we're going to come back to some of those questions as well when we talk about support needs for sure. Now, Keith and Cheryl, you have a bit of a different story. I would love to hear, I think each of you will have a kind of a part of the story to share likely, but Keith, we'll start with you if that's okay. Would love to hear your experience to learning you had a heart condition.
My name is Keith Haney. I'm a retired Chicago policeman. I finally made it to my destination that I wanted to get to. I didn't have any information that I had a heart incident. My church considers me as Mr. Miracle. That's what they call me, Mr. Miracle, because I had to find out what happened. So some of the information that I can share from what I found out, because I didn't know anything about it. So my wife is gonna help me take you on this, take this journey back. So 2018, January, right after I had my birthday, everything in my life happened to me in January. Everything that I came across happened to me in January. So my wife said, I'm gonna put you in a bubble. I'm gonna bubble wrap you in January because everything that happened to you in January. Got past my birthday. I had just taken my siblings, we go through a 6-month checkup because our parents were cancer. They all died of cancer. So we just get ourselves checked out. I just did my 6-month checkup. 2018, January 26th, I had just got off work. I was just getting ready to get off work from what she told me. I was just getting ready to get off work and I was in my squad car in uniform, but I was in my home district, which is Inglewood. And from what I found out, I wasn't feeling sick or anything like that. I found out I passed out while I was behind the wheel and I crashed into the back of somebody. 7 days, 2 weeks, whatever later, I found out that I had a I had a blockage that came up to my heart and shut my heart down. Just so happened how God works is that I was right by the firehouse on 60th and Ashland, right by the firehouse where it happened at. The ambulance was coming up. Ambulance was coming up and heard the call come out. They came up, and I found out that they found me unresponsive. They said I had flatlined, and they brought me back to life. They brought me back with a weak pulse, they said, and this wonderful 7th district said they opened up the street where they got to University of Chicago in a record amount of time. They took me right up into the surgery, found out I had a blockage that shut down my widowmaker, and they brought me back to life. From there, that's where she comes in.
So January 25th, 2018, nothing would have prepared me. I had just spoke to Keith on the phone, and he was on his way home, and I was on my way to a repast, but I just happened to stop by the house first. As I'm walking in the door, I was playing a game on my iPad. My iPad just kept dinging. So finally I looked at the messages and it said, "We're praying for both of you." And I'm like, okay. But then as I'm reading the messages, it says, "We're praying for you." I'm like, well, thank you for your prayers. By this time, the phone rang, and it was his best friend. And he called and he says, "Hey, Cheryl, what's going on? We keep getting these messages, that Haney is in the hospital." And I told him, I said, "Well, I don't know." He says, "Well, let me find out, and then I'll call you." The phone was ringing, and the doorbell rang. And I'm trying to get to the door first because I know I can just call back. So as I walk out of my room, I can see the street from my room. Nothing would have prepared me. As I walked out of the room, all I saw was a sea of blue lights, a sea of blue lights. I fell down the first flight of stairs, fell down the second flight of stairs. I'm crawling to the door. I'm not gonna tell you how many pair of shoes, but as I opened the door, the only consolation I had was there was not a white shirt standing at the door. The lady that was at the door, she says, "Well, I was in the district and I heard the call. I'm gonna get you to the hospital." Friday evening, she got me from 87th and Kedzie to University of Chicago Hospital in 9 minutes. When I got to the hospital, I've seen it on television, I've seen it before, but as I walked through that line of police officers, my heart dropped. I got in the hospital and I'm sitting in the waiting room. By this time, his unit is there. And so they come out and they said, "Well, he's in surgery." I said, "Surgery for what?" That's all they told me. They came back out and they told me, they said, "Well, he had a car accident." Still nothing. I'm sitting there, I'm nervous. They asked me, they said, "Well, do you have someone you want to call?" I was like, "No, I don't have anybody." So then, finally I realized, wait, he has a brother. So I called his brother, and let me say this, I did not go through this alone. These people sitting on this side of the room, they were there every step of the way. But we sat in the waiting room for 3.5 hours. My pastor came, I didn't even think to call him. I was talking to Miss Stanley, and she said, "Well, did you call Pastor?" And I said, "No." But they came, and when we walked up to that room, nothing would have prepared us for what we saw in that room. He was lying in the bed, and they had put him in a coma condition because they didn't know how long he had been down, so they had to calm his body down. For 3 days, he laid there, didn't say anything. We kept praying. The doctor finally came to me that second day, and he says, "Well, you need to make a decision." I went around the corner, and I cried, and I cried, and I cried. But then I prayed. And the Lord, he said, "He shall live, he shall not die." But he didn't tell me what condition he would be in. So we continued to go through. Then one day we're in the room, and his cousin came in, and he was praying, and he started to move. So we were like, okay, he is alive. So then they wanted to try to find out if he could respond to voices. But the long story short, January 25th to October 18th, when you see him sitting here, you don't believe in miracles, he is a living miracle. A living miracle. He had not been sick. He had no problems. He ran 5 miles every single day. We eat pretty well. He had just had a physical 2 days. But, we just say that was God's way of letting us know that he's still doing miracles.
Wow. Thank you for sharing. And so glad you had this community behind you too to support you and get you to the hospital so quickly and get you to the hospital so quickly. And And at the end of all of this, it came out that you ended up having a diagnosis of amyloidosis as well. Is that right? Oh my gosh. So not only are you navigating, recovering from this condition, from this heart event, but then also you're now navigating life with a rare disease. Wow. And again, thankfully, you had this really great and community behind you. And I want to talk for just a second about the importance of support. So you've got your lovely wife here who's providing support to you too. Can you talk a little bit about the support that you've had from your wife and your community and what kind of difference that's made for you?
It was life changing because I had never been sick, never, other than a cold I had, but I had never been sick. I've never had to put myself back together to be sick because it changed my life. When I talked to the doctors, you know, it wasn't that I had bad eating habits or anything like that because I was working out. I didn't smoke. I didn't drink. My wife cooked well. And to take a life change situation like that, whatever, it was tough because it put me in two mental states. It put me in two states. It put me in a state, whatever, where the only thing I could think is to get myself back well enough to go back to work, to doing what I like to do, being out there on the street and serving the people. And then it took me to the other state, mental state, whatever, that I didn't want to go on because there were roadblocks stopping me from going back to doing what I wanted to do and stuff like that. So I had to deal with two states to try to go back to where I was, and it was just tough.
So glad you had that support. And Cheryl, you know, I'd love to hear from you a little bit. Caregivers, you went from, you know, a wife to a very healthy husband to a caregiver overnight, right? And caregivers are so often doing so much for their families and their communities. But how do you take care of the caregiver? What support did you have?
When I say I have an amazing family, I need my brother-in-law to stand. While my husband was sick, my brother-in-law was my second husband. He made sure that I was taken care of. My sister came, she was living in Alabama. She came from Alabama. My sister-in-law, my nephews, you know, they were all there for me. My mom, you know, my mom practically moved in with us, and he was not an easy patient. And then let me not forget the men and women in blue. When I tell you they showed up, they came and shoveled my snow. They took me back and forth to the hospital. They were there the entire time. So, and then, of course, I cannot forget my church family. My pastor, if you need a good pastor, you need Dr. Johnny L. Miller. When I tell you he came to the hospital every single day he came. I finally had to tell him, okay, Pastor, we're good now, you know, because I know, you know, he has a busy life. You know, my other parents, Deacon and Mrs. Stanley. So when I tell you, I prayed so hard for him, I never thought to pray for me. But when I tell you my church family held me up in prayer, you know, they really did. It was a tough job. It was a tough job because I know he wanted to do something that at that moment he couldn't do. And as hard as he worked, you know, like he said, there were obstacles, but trying to support him, you know, but I had a great support unit. I mean, between my church, my family, you know, not one time did I ever feel just like giving up because sometimes, you know, being the caretaker, it's hard to deal with the patient. Did I say he was a difficult patient? But, you know.
Oh, well, thank you. I'm so glad, again, that you had such a strong community behind you. And Ms. Giselle, I know that you are also very aware of the need for community and support, especially as somebody's living with a rare condition like amyloidosis. I'd love for you to chat a little bit about what you've done to make sure that folks living with amyloidosis right here in Chicago have some support.
Well, just like Miss Haney, I've got my posse as well. When your friends from high school walk in the house and say, hey, Ma, that lets you know they've been there for me. My mom, when my dad passed, my mom moved in with me. I became an instant caregiver again because at one point, first of all, I'm my only child. So dad was sick and mom was sick at the same time. So I spent years going to their home on a daily basis to check up on them, make sure they got to their doctor's appointments. But when I say my posse has my back, my girlfriends, even my ex-boyfriend, which is strange, because when he came to the house, Mom said, I said, Mom, your boyfriend's here. Who, Thomas? So that lets you know I've got people that have my back. And not only that little angel over there you all are going to hear from later, Dr. Sarshwat, this is her passion. That's the first thing, to have a provider with a passion. But to answer your question, I became a health and wellness coach because of my parents and a couple of their siblings, trying to help them through their health issues, understanding the disparities in our communities. My worst patient, no, correct that, Giselle. My toughest patient was my mother. Diabetes, Parkinson's, hypertension, the list goes on and on. And her home caregivers would be in the house and I'd hear her. It's something about those ears with your children. That's now my parent. Give me an extra slice of cake, baby. Don't tell G. So this is my inspiration here, because knowledge is power. People need to understand what it takes to be healthy and stay healthy. You can't just take the medicine that the doctor gives you and go home and sit. You've got to be your own advocate. You've got to learn healthy habits, eating habits, and exercise. No, you don't have to jog like Mr. Haney, but you can take that walk from the living room to your back room 4 or 5 times a day just to build up your heart rate. So I am an advocate of trying to help people through their health issues and help them understand what it takes to stay healthy and live a quality life.
Thank you. Thank you. And in all of your packets, I believe, and on the table in the back, you can get some more information about Giselle has a fantastic support network for people living with amyloid here in the Chicago area. So thank you. Now, Ms. Jasmine, I know you've advocated for yourself and for your family members. And what I would love to ask you is, can you talk a little bit about the importance of knowing your family history and for advocating for yourself and your family members to get the care that you need?
Absolutely. What started it off, honestly, was me desiring to be in tune with my body. I had to understand everything that I was feeling so I would be able to give these same things that I was feeling to the doctors that sat in front of me. It isn't easy, especially if it falls on deaf ears, but I never allowed it to stop me from seeking the doctors that actually care, that's going to put in the work. And even if it seems impossible, it's not. Was it a journey that was challenging to me? Yes, but it was a journey that I was willing to take because of the level and the type of team that I have with hidden diseases that's inside of me. I don't just have amyloid from my father. I also have Leiden factor 5, which is a blood clotting disease that a lot of us don't know that we have. And it affects women in such a way that it affects our pregnancies. It affects when we are receiving any form of hormone. We cannot receive hormone because of this blood disease, and not many of us know. Especially during childbearing years, it's hard. I've had to watch my daughter, who also have this genetic disease. It was very important for her doctors to know how to help treat her and to help carry her second baby. It was hard to see, but I was grateful to know. And what I got to see when my daughter couldn't go a full 9 months carrying her own baby, the team of doctors that pulled in together to make sure that not only my baby's life, she was going to be able to open her eyes to see her baby. They worked around the clock. It was hard, but I was grateful to see that level of care go into this Black woman who was having a baby with this disease. So many of us go into these rooms and into these operating rooms, and they don't know much about us. They don't know the details about us. And all we need is a group of doctors that's going to want to know every detail about us. I've had doctors walk out of hospital rooms because all I said to them was, before you come in here to treat me, please read and know about me. Know who you're coming in to see. And yeah, she walked back out just because I said that to her. How fair is that to me? How fair is that to anyone? To where when you're in a state to be treated and cared for, a doctor don't even want to take the time to know you. How are you going to treat me? How are you going to explain to me that this medication that I need in my body is going to help me if you can't even read about me? I fought. And it was a level of fight that I did for me, a level of fight that I'm choosing to do not only for my family. I have been in these spaces, hospital and clinics with my family, to say, hey, you're going to see them. It's hard having to be with family and to hear doctors say, no, you don't need that type of testing unless something happened to you. How fair? And I said, no, we have genetic diseases in our family we need to know about. My sister not only is important, but her daughter and her grandchildren, they are important. Let us know these things now. You need to know these things now, not when something happened. And even if they're not genetic, and if it happens to you, share it. Say it, because there is someone out there who can connect. Look at us up here. Me and Giselle have the same story. Her father. I'm learning so much from her, from this disease. Getting to know him and this wonderful wife of his who took the time to take care of him. Without a doubt, she did it. And there was a disease lying within him that he knew nothing about. We are important, and it is time for us to let these clinics and hospitals that serve us know we are important when we walk through these doors. I do it, I say it, because it's hard to see these doctors and medical students in the office with us. And they're giving us the minimum, no more. There are things we need to know. There are things that we have to involve ourselves in with our lives, because that's what it took for me to get the team that I have. I live in Hanover Park. I drive to the south side of Chicago for Dr. Sarswat at the University of Chicago. My pain doctor is at North Shore, in Skokie and Glenview. I drive out there because they take care of me. These are doctors who have listened. I drive to Rush. My neurologist is there. These are separate locations, but these doctors work with me like they are in the same facility. We deserve that. We can have it. When the hospitals say we cannot do that, they're lying. It is time to challenge them. We deserve a higher level of care for things that's going on in our bodies. We are worth it, and we need it, we desire it, and we are speaking here. That is why we wanted you guys to come out today and tomorrow. Let's do this. I've been waiting. I'm not going to lie. I've been waiting to have a conversation like this. There are things that I have gone through outside of my community, from the South Side to the suburbs. I want to share it with you. It's time. It is time for us to get what we deserve. That's all.
Thank you. Thank you so much. Thank you all for sharing your stories. Thank you for sharing the importance of community, of supporting each other, of advocating for yourselves, your families, and your communities. And excited to hear more from the experts so that all of us here in the audience here today and tomorrow can have the tools and resources that you need to advocate for yourselves and your families and communities as well. Thank you.
Thank you very much, Colleen. And give another hand, please, to Keith, Cheryl, Giselle, and Jasmine. Please, thank you. So as we said, it's interesting. Hearing from patients and caregivers has a far greater gravitas than hearing a very similar statement coming from physicians. I don't know about you, Dr. Saunders. I don't know about you, Dr. Sarswat. We may talk, but they really listen when they hear it from a peer. And so their words carry great meaning. And I'll say one other thing. Advocacy came out a couple of times. So those of you who have not, and I'm sure there's nobody in this room, but those of you who have not registered, please do. Those of you who had any inkling of not going out to vote, because where does healthcare begin? With health policy. And health policy begins with who we vote for. So let's make sure we do that. We're going to drill down to what ATTR cardiomyopathy is. But first, let's get a better view of what cardiac disease really is. What is heart problems? And to give us a discussion about health disparities, prevention, early detection, and management, we'll have as our next speaker, Dr. Lawrence Sanders. Dr. Sanders is a graduate of the Vanderbilt Medical School. He did a residency in internal medicine at Emory University down there in Atlanta. For those of you who know, that's further south than where we are here in Chicago. He is the past president of the Atlanta Medical Association, past president of the Georgia State Medical Association, and he was also the past president of the National Medical Association. For those of you who may not know, that is the largest organization of African-American physicians in the country. He is currently the deputy medical director at the Grady Health System, also down there in Atlanta, and he's the chief medical officer for Heal Collaborative. I give you Dr. Sanders telling us a little bit about what heart disease is. Thanks, sir.
I think it's afternoon now. First of all, giving honor to God who makes it possible for us to be here and gives us the wisdom to make this conversation and this dialogue meaningful to each of us. And I also want to thank the pastor for opening up this place for us and each of you for coming to talk and listen to what we have today. And I say talk because it's really the communication between each of you that helps us move this forward. What I'd like to do then for the next few minutes is I want to talk about heart disease, but I want to anchor off what we just heard, because I think what we heard were clear descriptions of symptoms, of how it emerges in your daily life, and where there may be no symptoms and there's a vent. And that disease does not only impact one person. So what I want to do now is take a step back from amyloid, from hereditary amyloid, and I'll put it in perspective. But I really want to just talk for a few minutes, picking up on the title of the program, What's Breaking My Heart. I'd like to talk about heart disease from a broader perspective. My goal is to say, what is it? How common is it? How do I know if I have it? What should I do? And then what should I do to take care of my heart? So those are the things I want to do in the next few minutes, all right? Next slide. All right, heart disease is the leading cause of death in the United States, but not only in the United States, but across the world. Heart disease, often we say that about 1 in every 5, 1 in every 3, 4, 5 deaths is due to heart disease. Somewhere around 700,000 people every year die of heart disease. You'll see the other leading causes of death there in 2022, which are heart disease, cancer, and unintentional injuries. Unintentional injuries are those things where we do things to ourselves with guns, with knives, with other things. But you'll see cancer and heart disease at the top. You'll hear later on about the disparities, but I also want to make one point. If you look at that box down in the corner, it says leading causes of death in 1900. And you'll see that there are, at the top of that, you'll see influenza, tuberculosis, diarrhea. We've done well with those things. We've done well with treating infectious diseases. But then you see heart disease, stroke, kidney disease, accidents, which is unintentional injuries, and then finally cancer. And if you look at those same diseases, you'll see we haven't made a whole lot of progress since the turn of the last century, and that heart disease still continues to be a problem for us. Next slide. So what is this thing called heart disease? It's a big bucket for a lot of different conditions that impact or affect the way the heart functions. I think you heard about coronary artery disease or a heart attack. Most of us think about heart disease, and the first thing we think about is a heart attack. That's only one type of heart disease. And it's really when if you see that picture of the heart, you'll notice that the heart is really a muscle. And it needs blood supply, just like your leg needs blood supply. But the other interesting thing about the heart is it has to keep the rhythm and keep beating because it has to pump blood out to all the other organs. So the heart has an electrical function. So something can go wrong with any of those things. And what happens with a heart attack? It is those blood vessels around the heart that get clogged up with any number of different things. But the way I usually try to put that in perspective, I'm a Southerner, so fried chicken, you fry that chicken, how many of you pour the grease down the drain? Because what happens if you pour the grease down the drain? It clogs up the drain, right? But we keep on eating it, and it clogs up our vessels. All right, and so that's really what causes the heart attack. Those vessels, those little blue and red things there, get clogged up, and that's what causes a heart attack. Now, the heart attack and coronary artery disease is the leading cause of cardiac death. It is the #1 heart disease. It accounts for about half of all heart disease. So coronary artery disease is real. It's important to think about it. But things can happen to the muscle, things can happen to the valves in the heart, and things can happen to the electrical system of the heart. Next slide. And so what this slide means to do is to show you what the wide range of heart disease is, all right? At the top of it in the corner, there's coronary artery disease, which we talked about, which you've heard about. And you come on around, you see that things can go wrong with the valves in the heart. Those are the mechanisms that keep the blood separated in different parts of the heart. You can get that same stuff from eating too much fried chicken, clogging up those valves. You can have infections of the valves. You can have genetic disease of the valves, so they can go wrong, and we can treat that. You come on around and you'll see that you can have what's called an aneurysm. The way I put that in perspective, for those of you who are old enough to know when a bicycle had an inner tube, and that inner tube would get weak, and it would poke out, and it would stick out, the inside would stick out. That's what an aneurysm is. Those vessels get weak, and the inside doesn't break, but it kind of pokes out like it's weak, and it can bust and have other problems. So that's what the aneurysm part of it. We come on around, you can have cardiac arrhythmias, where your heart beats too fast, where it beats irregularly, or where it beats too slow, or where it just stops altogether sometimes. So those are the arrhythmias. You come on around and you talk about the muscle. And I think what we've heard about today is amyloid, which impacts the heart muscle. And we'll hear more about it as we go, because it is the accumulation of a protein in that heart muscle. But that muscle can get infected. That muscle can grow too big because of other genetic problems, because of other heart diseases. And so there are a number of things that can happen to that muscle of the heart. And then the heart has a coating around it, and we call that the pericardium. And that pericardium can get infected, and your heart just can't beat enough. It gets restricted, and you get some of the symptoms that you heard about. And also you can get what we call heart failure. That's a result of high blood pressure. That's a result of any number of diseases where your heart just gets dilated and it can't pump the blood. Now let's go to the next slide. The interesting thing is that all of these diseases can have similar symptoms. And I think if you listen to the group before us, you heard all of these symptoms. You heard everything. You heard everything from sweating, lightheadedness, shortness of breath, to just my chest didn't feel good. It was uncomfortable. You heard nausea, vomiting, heartburn. You heard other things. You heard difficulty sleeping. You heard inability to handle exercise. I just couldn't do what I used to do. And that's important to pay attention to, because there's only one person that knows your body better than anybody else, and that's you. So what should you do if you have any of these symptoms? Next slide. You need to go and see your primary care physician before somebody has to take you to the emergency room. I'm gonna say that again. If you have these symptoms, you need to go and see your primary care physician before somebody has to take you to the emergency room. That's two different things. It's better to go on your own than to be taken. Now, that's not as all easy, because most of us, particularly those of us who look like me and men, we don't want nothing to do with this. Nothing. I don't want to be sick. I don't want to think about it. And most of us end up getting taken to the emergency room. So we got to do something about that. But now, what happens when you go to the primary care physician? That's your starting point. That's your starting point to the healthcare system. And one of the things I heard is the power of the relationship between patients and their physicians, and how important that is. And to me, that the most important skill that a physician can bring to the table here is the ability to listen. First of all, they got to listen to what your story is, what your symptoms are. And if they don't listen and you feel like they're not listening, just like you do anything else, go find another one. All right? That's your choice. Get up and go find another one. And I also put in here that I think the important thing is they have to learn a little bit about you, more than a little bit about you. I'm a Southerner's country boy, so when I say a little bit, that means a lot. All right? So they need to be willing to listen to about you, learn about you as a person, learn about your personal history, learn about your family history, because all of those things go together. The next thing they need to do is do a physical examination. You know, in today's world, some of my colleagues believe that they can get everything from talking to you and by looking at the computer. I'm old school. You really got to take the time as a physician to listen to the patient, to connect their symptoms to what you hear, what you feel, what you see, because that then allows you to make a diagnosis, but not only that, but to understand better how the treatments that you might prescribe are going to impact that patient. And the physician may order some diagnostic tests, which means you got to go get some things done. I think I heard about the genetic testing and how it made you nervous, how it made you uncomfortable, how you were worried. I think if you have to go for any of these diagnostic tests, it's not an easy thing. It's something that you have to get through. And your support system is what helps you get through it. And if any of these tests are positive, or the findings suggest that you need to go see another physician, then that's where your primary care physician can engage cardiology or whomever. Now, why start with the primary care physician rather than go to the cardiologist directly? Because I think one of the other things that you heard in the panel previously is very few of these things occur one thing at a time. I heard diabetes, I heard a number of other factors. I heard clotting problems, and it is your primary care physician that helps keep all of these things connected and will help you look at the whole picture. Now, I got a feeling that our cardiologist here is pretty good at looking at the whole picture and really taking care of people from everything I've heard so far. And I think that's important. But it's really about building that relationship with your physician, because that's where the information and everything gets transferred. You know, it's not about me being up here and figuring out what's something on. I can't make a diagnosis. I can't prescribe a treatment without interacting with you as a patient, as a human being. And that becomes really important. Next slide. So what happens if you have this? Well, there are a number of things that can happen. I think we heard about surgery. Surgery is one treatment. For coronary artery disease, at one point, surgery was the primary treatment. And that picture of the heart there is meant to show you what happened with open heart surgery in the beginning. And that was that we would try to take a vein from another place and patch it across the artery where it was blocked. Now, we can do a number of different things today. We can do that by putting a catheter up through your arm. It used to be in your leg, but we can open it up just like you would open up that drain that I talked about from the fried chicken when you pour that grease down the drain. That's what happens. But what we want to do is prevent that. And I'll talk a little bit about that in a minute. So surgery is one thing, but it's not the only thing. You're going to have to change your lifestyle. I think I heard that 3 or 4 times from the panel about changing your lifestyle. If you smoke, you need to quit. You need to change your diet. I mean, fried chicken every now and then is not a problem, but if you eat it every day, that's a problem. If you eat fried foods, we got to move away from saturated fats. The more color on your plate, the better off you are. The more color on your plate, the better off you are. And I heard it here. Well, you may not be ready to start jogging just yet, but you can start a walking program. See, what happens to most of us as we get old, we feel like if we're going to exercise, we're going to go back and try what we did when we were in high school. And then the next day, you can't move, and you say, I'm not going to do that no more. And so I'm not telling you a story that I don't know about, okay? Because before I was a doctor, I was human, and I'm still human, and I probably behave not different from many of you. And so you just got to start slowly and go carefully, all right? And then if your doctor gives you medicines, may want to treat your high blood pressure, we can treat heart failure, we can treat any number of different things with the medicine. But if that medicine sits on the counter and you just look at it, it's not going to do you any good. You got to take that medicine. And that's where you may need somebody to help you and be your support, even if they have to take it out of the bottle and give it to you the first few times. All right? You know, one of the things that I remember from medical school, and I haven't forgotten, is that one of my professors, his point was that it is your responsibility as a physician to really create the framework such that patient can adhere to their medicine. All right? I went, now wait a minute, that's their problem, that's not mine. Why should I do that? But here's what I put. You know, when I was in the 10th grade, I wanted a pair of Converse tennis shoes. And at that time, I think they were $12, right? If those shoe manufacturing companies can take that $12 tennis shoe and sell it to us for $250, we ought to be able to figure out how to help people take their medicine. So the most important thing is that you got to take that medicine. And then you may need to take part in a cardiac rehab program. And what I would say is not rehab. I think we may need to get into these cardiac programs before the event, such that it's not rehab, but it gives us a structured environment to make the necessary life changes. All right, next slide. So what are the risk factors? So how do you take control and take care of your heart? I think I've talked a little bit about that. You've heard a lot about that. cholesterol. Got to bring the cholesterol down. We can do it by medicines. We can do it by the food that you eat. If you got high blood pressure, we got to bring down that blood pressure. We can do it by exercising. We can do it by medicines. And we can do it by changing your diet. If you got diabetes, diabetes is another one of those diseases that interacts with the heart and interacts with heart disease. So if you got diabetes, you got to keep it under control. You know, you got to make sure that your blood sugar stays within the range and that you do the things necessary to control your diabetes. If you're overweight, you got to lose some weight. And the best way to do that is push yourself back from the table. All right? And if you got kidney disease, we need to deal with that. And sometimes that doesn't necessarily have diet problems. But if you think about it, high blood pressure, diabetes, all of those go into causing your kidneys not to work as well. And so they're all linked together. So you see why I said in the beginning that it's a good idea to have a primary care physician, because their job, their role is to help connect all of these things and see you as a whole individual. And if you smoke, stop smoking. Harmful use or overuse of alcohol can also put you at risk for heart disease. So responsible use of alcohol is where we are. And if you sit in that couch chair all day long watching TV, it's not going to help you at all. So you see that the things that you have to do to prevent this is you got to get up, you got to look at what you eat, you got to get some exercise, and you got to be disciplined about what you put inside this body, because you only got one. All right, next slide. Now, I don't know how many times I've said the word food since I started, and how many times I've talked about what we eat. If you remember back in elementary school, one of the things that I remember there is that you become what you eat. You become what you eat. And if you eat healthy, you're more likely to be healthy. And you know, it would be nice if it happened tomorrow. If I ate bad today and it happened tomorrow, but it may be 10 years. It may be 15. It may be 20. So it's about keeping that diet and watching what you eat every day. And the most important thing is the more color you have on your plate, the more fruits and vegetables, the more fresh fruits and vegetables you have on your plate, the better off you are. And this point is to make that you can find good guides in the packet that you have in the back. You can find them online, and you can find them any number of places. But what you have to do is find them and stick to it. All right? Next slide, last slide. This is how I'm going to end, and this is from, I think, a famous woman from Chicago, and that it is often not easy about finding your way through a world loaded with obstacles. And this is a world loaded with obstacles that either you don't see or others don't see. And that's why you need people to help you. And I think there'll be time for a discussion. I hope this made you think a little bit and think about heart disease and sets the stage to talk about amyloid.
Thank you very, very much, Dr. Sanders. As Dr. Sanders mentioned, at the end of all of our speakers, we'll have a chance for a question and answers, and we'll take them then. But you know, while listening to Dr. Sanders, I'm from Kentucky, so I'm gonna have to sit up here and protest. You know, we get that finger-licking good stuff down there. And so you quit talking about Kentucky Fried Chicken. But tomorrow, we're gonna have a very nice discussion about heart-healthy eating. So if you're here today and you want to hear some of that and see what Dr. Sanders was talking about, particularly those different things, vegetables on the plate, very important. You know, I know Michael Jordan had a posse. You know, I know Cab Williams, your quarterback up here, has, but I never heard of a cardiologist having a posse. I mean, this is ridiculous. All the people talking about Dr. Saraswat. I mean, come on, man. Anyway, what am I going to do? So Dr. Natija Saraswat is our next speaker. She's going to be speaking to us today about what is amyloidosis, a rare hereditary disorder. Dr. Saraswat is a graduate of the Medical School of McGill University at Northwestern University. She's an internal medicine residency at New York University Grossman School of Medicine. She did a cardiovascular fellowship at Cooper Memorial School of Medicine at Rowan University, Cooper University Hospital. Camden, right? Yeah, that's right. Good old Camden. Yay. Anyway. She also did a fellowship in cardiovascular disease, another one at the Massachusetts General Hospital. She currently assistant professor, Department of Medicine and Cardiologist at the University of Chicago School of Medicine. I guess she needs no introduction. Dr. Sarswat. Thank you very much.
All right, thanks for letting me be here today. Sorry, it's kind of reverberating. Why am I here today? I'm passionate about this disease. This is something that in medical school 25 years ago, they said, you're never gonna see it. Memorize these little slides for the test, you're good. You'll never actually see it in patients. Not true at all. But that sentiment carries through to so many physicians, so many providers today, and this is why we need to put the power back to you guys, because there are so many people that trained in an era where they had no idea what this disease was. And they said, we're not gonna see it. Now we've come a long way since then. This has gone from a disease that you'd get online and you start Googling and you say, I'm gonna die. I'm gonna die in a year. And you feel sad and you feel in despair, to a disease where we have treatments, we have hope, and people live long, happy, healthy lives. And the earlier we catch this, the better, the more treatable it is, and the longer you live, and the more time you have with your family having a good quality of life. But that's why we call it a new paradigm. This has changed, and it's still changing, and what we're gonna talk about are all these new treatments on the horizon. There are new things coming up every day. The field is changing, and there's a lot of hope coming down the pipeline. Next slide. So what is amyloidosis? We keep talking about this. What does this mean? Amyloidosis is actually a group of diseases where proteins that are in your body misfold. When they misfold, they like to bunch together and deposit all over the body. It can be very systemic, and that's part of the challenge of why it is so hard for physicians, nurse practitioners, for all providers to diagnose this disease. You guys know modern medicine today, right? I was talking about this with somebody else earlier, right? There's a physician for your right pinky, there's a different physician for your right nostril. Everything is so super specialized that what you need is somebody who puts those pieces together. And you can put those pieces together and think about this disease as long as it's in your brain and you have that suspicion. And if it's in your suspicion, and this is for you guys, this is for the medical students, this is for everybody, right? If you think about it, you won't forget it, and you'll as long as you think about it, you're not gonna miss it. So there are different kinds of amyloid. The first one on the left there is what's called AL amyloid. That's not the focus of today's discussion, but if you get online and you Google, I want you to know about it. It's a bone marrow problem that we treat with chemotherapy. It's not a cancer, but it's very similar to a cancer, okay? That's different than the diseases that we're talking here. It's not a hereditary disease and very different. The second one is what's called AA amyloid. This can also affect the heart. We see this in inflammatory diseases like Crohn's disease, like tuberculosis. Not the focus of today's discussion, but important for you to know that there are other types. On the right there is TTR amyloid. That's what we're talking about today. TTR amyloid is because there's a protein called the transthyretin protein that's made in the liver, and that protein misfolds. When it misfolds, it likes to deposit all over the body. There are two types of transthyretin. What's called wild type, which means we don't really know why it happens. It's probably from aging, we're not really sure. And then the hereditary type that you've heard about today, that's because of an abnormality or a variant in the DNA, the building blocks that make us who we are. Next slide. So to talk about TTR, the transthyretin protein, again, made in the liver. I always tell patients it's kind of like a four-leaf clover, right? There's 4 parts to this protein, and this is important because that 4-leaf clover likes to fall apart into 1-leaf clovers, but then all bunch together and deposit in those places. It can cause heart problems, the cardiomyopathies that we're going to talk about. It can cause nerve problems. It can cause a myriad of things. And the more we learn about this disease, we realize the more issues throughout the body it can cause and the more systemic it is. Next slide. So we've seen a couple pictures of the heart. The difference in this heart, which is an amyloid heart, is that muscle becomes very thick. That muscle becomes very thick because the protein deposits in the muscle. When that happens, the heart doesn't relax. It fills up with fluid, and kind of think of it like the plumbing gets backed up. The plumbing gets backed up, it's going, the blood and fluid goes into your lungs, makes you short of breath. You can go backwards into the belly, causes swelling in the belly, swelling in the legs. All of that can cause heart failure. Heart failure sounds like a very scary term. I hate it, right? It implies that we're failing. It's just a term. It means that It's a syndrome where you have a tendency to feel tired, tendency to feel short of breath, and fill up with fluid. It's a big spectrum, right? There are people with heart failure that can't walk across this room, and there are people with heart failure that can run a mile. It's a big spectrum. But what we worry about is that this leads to extended heart failure. And when we catch it earlier, we prevent that from happening. And that's the importance of, again, getting tested, finding it out early. Next slide. So everybody keeps talking about this as being a rare disease. I don't know. Is it really rare? We know, as we talked about, that the hereditary form and one of the common gene variants that we're going to talk about is in 4% of African Americans. That's 1 in 25. Now, not everybody who has the gene variant gets the disease, but that's a lot of people. When we look at autopsies of hearts, people who have passed away, we look at older people, we see that a lot of people actually have amyloid in their heart. It's a lot more than you think. Probably 10 to 15% of people, when they die, have some level of amyloid in their heart. So again, not so rare. We talk about heart failure. It's probably the cause of about 10% of heart failure. That's a lot of patients. That's a lot of people. Not really so rare. We talk about mortality, right? This is the big thing in what we do. Keeping people alive. So you go online, you start Googling again after today, and you start reading, oh my gosh, I'm going to live for only 6 months after this disease. Not true. These are the things that you're going to find online. Now with our treatments, people are living longer and longer. I have people I've been seeing for 10 years that are enjoying time with their families. So what we haven't figured out is, what is the mortality with modern treatment? I don't know, because all these treatments are just coming, but they are getting better and better, and people are living longer and longer. Next slide. Sorry, keep going. So this is part of the reason, again, that it is hard for providers, physicians to diagnose. Amyloidosis can cause such a myriad of symptoms. It can cause numbness and tingling in your feet. It can cause carpal tunnel that you heard Giselle talk about. It can cause spinal stenosis, back pain. It can cause heart failure, atrial fibrillation, a common rhythm abnormality that you hear about. People end up with pacemakers. It can cause dizziness with changes in position, cause urinary retention, sexual dysfunction. You see all of these different things, and that's why it's so hard for somebody, again, to put those pieces together. Which is why, unfortunately, a lot of time the onus comes onto you as a patient to say, shoot, I got 2 or 3 of those things. Let me put this together and go tell my doctor, could this be amyloid? What we're trying to do as a medical community is do things to help us identify people earlier. We use our electronic medical records. You hear about artificial intelligence in the news today. We're trying to do things like that to catch people earlier, to try and get into the systems to figure it out earlier, so it doesn't come to the point that you have all these symptoms already and then somebody starts to figure it out. Next slide. Amyloidosis also causes a lot of problems with quality of life. So it's not just mortality. The things that I hear in clinic all day long. I have so much diarrhea. Every time I eat, they have GI involvement of the amyloid. Every time I eat, I have to run to the bathroom because I have diarrhea. I can't leave my house because I have so much diarrhea. I can't stand up off of a chair without feeling like I'm going to pass out. I'm so short of breath all the time that I can't go be with my grandchildren because I'm filled up with fluid all the time, right? So it really affects quality of life. And again, why we want to catch this before you get there. Next slide. So what do we do as cardiologists to figure out if there is amyloid in the heart? So some tests that you might hear about on the upper left side is just an ultrasound of the heart that allows us to see, is the muscle thick? How well is the pumping function of the heart working? And we have kind of signs, and there's something called a sparkliness of the heart muscle that gives us a clue that maybe there's amyloid in the heart. On the upper right side, you see an MRI. Sometimes we get MRIs of the heart to help us understand how much amyloid there is. Is there really amyloid there? This is just some of the testing you might go through if you're going through a diagnosis. The bottom right is something called a PYP. So up until 2016, to diagnose this, I would have to take a piece of your heart. Literally, I would have to biopsy the heart. This new test came out in 2016. It's just an imaging test. And that imaging test allows us to diagnose the amyloid without anything invasive, kind of like taking a CAT scan or a stress test. That's been a game changer, right? I meet people who are 90 years old that we think have amyloid. Do they want to go through a biopsy of the heart? Tell them, I'll put you in a little scanner for a few minutes. That helps us diagnose this earlier. So if you have some suspicions, here's some of the tests that you may go through. Next slide. This is an algorithm that we have. We're coming along here. So if somebody has a suspicion, now we have published guidelines for physicians to follow, right? You could Google this again. That helps tell people, okay, I may have amyloid, where do I go from here? But a lot of that is really ruling out the other kinds of amyloid, getting that PYP study, the imaging test, to look for amyloid in the heart, and then understanding if you have TTR amyloid, transthyretin amyloid, is it wild type or hereditary? And the way we do that is genetic testing. You're going to hear a lot about genetic testing from Rachel, who's our fabulous genetic counselor who's talking next. But the importance of the genetic testing is not only for your family, but also for every amyloid patient. Because our treatments right now actually are different for the hereditary type and the wild type. Genetic counseling used to be something that everybody was scared of, or genetic testing was something that everybody was scared about. What does this mean? Everybody has my information. How much are you going to charge for my genetic testing? It's easy now. You spit in a cup, it takes DNA from your cheek cells. It makes things so much easier. We've had a lot of people, they just literally send the kit back to the company and get results in a couple weeks. Insurance cannot raise your rates. It's not going to affect that. That's a law. You'll hear more about this from Rachel. But that's how we differentiate the hereditary type from the wild type. Next slide. Sorry, you can just keep going through this. So when we talk about the difference between the wild type and hereditary, wild type, again, is that one that generally affects men more than women. We don't know why. Often affects Caucasians more than other people. We don't know why. And often affects the heart more than anything else. Whereas the hereditary type, with an abnormality in the DNA, can cause nerve problems, GI problems, heart problems. It's more systemic. That's a good way of thinking between the different here. As you can see on the right side, basically what we're seeing is that we're winning against this disease. Not only do we have treatments, but we're diagnosing more and more people. When I came to University of Chicago almost 10 years ago, there was no program, nobody knew what type of amyloid anybody had, there was no treatment. Now we're diagnosing more and more people by doing things like this, by you guys advocating for yourselves and getting the word out. Next slide. So again, as you see with time, we're learning more about this disease. And it's not that it was rare and now it was rare before and now it's common. It's that we're picking it up. We're winning. And this is why we're here. Next slide. So as we also diagnosed earlier, people again are living longer and longer. So what we see is that the survival is getting better and better. The earlier you're diagnosed, the longer you live. Again, to prevention, to advocating for yourself, don't wait till you can't breathe to come to the hospital. Go see your primary care physician, figure out what's happening earlier, because now we're realizing that we can diagnose this early and we can treat it early. Next slide. So again, back to genetic testing. So we know of over 120 different genetic variants. That means those changes in the DNA from the normal population that cause amyloid. Does this affect only African Americans? No, but it happens to be the most common genetic variant in the United States. In the United States, again, 4% of African Americans have what's called the valine isoleucine mutation. Now, there's a common mutation that we see in Irish, that we see in Portuguese. This doesn't affect just African Americans, but in the United States, that's who it's affecting. This is the community that we need to have these discussions in so we can be out there and recognize it early. Next slide. And again, understanding, especially with the valine isoleucine mutation, what happens? The timeline of it. Once you develop heart failure or heart problems, you've already at the end of the timeline. We want to catch you early when you're having carpal tunnel, when you have spinal issues, all the way at the beginning, when you start having eye issues like glaucoma, and recognizing that. Giselle mentioned her bilateral carpal tunnel disease, right? That's where the amyloid protein deposits in the wrist and causes numbness and tingling in these 3 fingers. And what we realize, if that's in both hands, there's a high chance that that's development of amyloid. So we work with the orthopedic surgeons now and say, hey, you're gonna go do this surgery, take a little piece of tissue. Let's make sure. Does this person have amyloid if they have it in both hands? And we can catch it early. So we're trying these things as a medical community, but we got a long ways to go. So understanding that timeline is important. Next slide. So let's talk a little bit about treatment. Next slide. So our normal treatment for heart failure, we have medications like metoprolol, like Entresto, Jardiance, all of those things that you hear about on TV. Most of them in amyloid, they don't work. They don't help. They're not treating the underlying problem. And most of those medications actually make patients with amyloid feel worse. And one of the best things I can do in clinic is a patient comes to my clinic and I start taking away medications. And they're like, no doctor's ever stopped my medications. Everybody gives me more pills, more stuff. But it's because most people with amyloid don't tolerate those medications and they don't help. So important to be with somebody that understands the disease. Next slide. Big things. I'm a transplant cardiologist. There are times that we do transplant for people with amyloid. It's rare. We have good treatments, right? People are living longer and longer, but just so you know, there are rare times that it happens, that a heart transplant would happen if somebody's young and they have very severe heart failure. Similarly, you might hear about something called an LVAD, which is a heart pump. There are rare times that these heart pumps are used for people with amyloid. Next slide. Can you just step through there's a lot of pushing here. So what do we have in terms of treatment now? 5 years ago, I had nothing. Now we got this whole armamentarium of drugs to treat this disease. So we can stop the production of the protein in the liver. We have what are called silencers. These are medications that are injections, some of them injections once a month, some of them injections a few times a year, that actually prevent the protein from being made. They make the nerves feel better, and now we're realizing they also make the heart feel better. So we have 4 treatments that are called silencers. We actually are starting clinical trials for DNA editing. I thought this was 10 years away, right? It sounds voodoo, space stuff that we're gonna change your DNA. It's here. We have clinical trials that are starting right now where you get a one-time IV infusion and it changes your DNA and is potentially curative for amyloid. We got a lot of hope. Then we have what's called stabilizers. Those keep that protein in the 4-leaf clover. Those are pills, once a day, well tolerated, people feel well. They make you feel better, keep you out of the hospital and make you live longer. The new kid on the block, we have some new medications, and these are still clinical trials, that actually eat up the amyloid in the heart. So we've gone from having no treatments to having some treatments that slow the progression of the disease, to now having medications that potentially reverse the disease and eat up any amyloid that's there. We're learning. You can see all the hope that's coming down the pipeline, but there's a lot of things that we still don't know, a lot of things we still have to learn. Next slide. These are just our ongoing clinical trials. So again, so you see how much active research there is in this, how much hope there is. And this is from, industry companies like AstraZeneca that's sponsoring things here today. We're trying to find new treatments all the time. We're all working hard to make lives better. Next slide. So there's still a lot of things we don't know. We don't know how to use these drugs together. We're still coming up with new treatments. But the big thing that we do know, earlier diagnosis is better, people will live longer, and that this is changing the whole disease from something that was rare and is going to cause you to die to just another chronic cardiovascular condition like coronary artery disease that we talked about. Next slide. That's all I got, and that's my contact info for anybody that wants to talk.
Thank you, Dr. Sarswat. I think that was great the way you took us through that. I hope you didn't mean for everybody to go out and start Googling everything, because sometimes that can open a torrent of information that we sometimes don't need. But I will recommend at least 2 sites for you to go to. If you just go to your web browser, put in AstraZeneca and ATTR, you'll get some really, really good information. Or put in University of Chicago and ATTR, again, you'll get some nice information there too. If you just put ATTR in your web browser, you'll get a whole bunch of stuff from some folks. Yeah, some of it is good, some of it is not as good. But that's one way you can get some really good information if you put AstraZeneca, ATTR, and University of Chicago, ATTR. And of course, I'm sure that Dr. Sarswat will be happy for you to give her a call. At 1 o'clock in the morning, you're not doing anything, you're a little concerned, give her a call and she'll want to sit down and talk to you a little bit about things. I think it was very nice the way everything was set up for our final speaker here. And remember, if you have questions, just write them down and we'll have a panel discussion afterwards. Ms. Rachel Campagna, or Bernstein, Campagna just sounds so much better, will be talking to us about genetic testing and essentially what do my genes have to do with it. Ms. Campagna got her BS in genetics and psychology from the University of Wisconsin-Madison and a master's degree in genetic counseling from Indiana State University. She's currently a cardiovascular genetic counselor at the University of Chicago School of Medicine. Give you a minute to get everything set up. And this is one of the most exciting things that you can think about in terms of how we start making diagnoses and how things have changed since I started off so long ago. And it's really fascinating to hear what's coming along for us. Thank you.
Thank you. Give them a second to get slides up. But I think we've heard a lot throughout our panel and obviously Dr. Sarswat about the importance of genetic testing in especially amyloid. I'm gonna have us take kind of a big step back and talk about genetic testing in various different types of heart disease, knowing that like amyloid is kind of the big thing today. But I think it is October is Sudden Cardiac Death Awareness Month, which I think is important. And B, which I'll talk about in a moment as well, November is Family History Awareness Month. So coming up can't believe it's only like a week or 2 before November starts. So everybody get ready to start talking about your family history around that Thanksgiving table. So I'm gonna start with one of the questions that I get asked in clinic all the time, which is, I already have heart disease. Stop asking about my family and talk to me about me. And yes, I think that's super important to do with your doctors because I'm not a doctor. I'm a genetic counselor. I'm actually designed, my job is to talk to you about your family, to gather that data, to share it with your doctors, whether it's your cardiologist like Dr. Sarswat, whether it's your primary care provider, whether it's just sending your family tree back to you so you can share it with your family. I know plenty of patients have asked me to do that, and you do have in your folders the family history form, or at least a start of one, that I actually made for Jasmine's family to help keep everything just in one place. So that's kind of what I'm here to talk about. But, oops, sorry, I forgot that I have to ask for the next slide, please. I think it's important for us to all be on the same page to start with in terms of language. So when we're talking about genetics as a whole, we're talking about what you get from both of your parents. So we all, as humans, should have our 23 pairs of chromosomes. One comes from each of our biological parents. Along those chromosomes are thousands and thousands of genes. And those genes are basically little individual instructions for everything in our bodies, from our hair color, to our eye color, to our height, to the way our heart develops in the first place, to the way our heart functions throughout life, to the way it responds throughout life. So when we're talking about doing genetic testing, we're talking about really looking at that instruction manual for your heart. I kind of think about it in like layman's terms. Remember those like big Encyclopedia Britannicas that used to be at the library before the internet kind of came along and ruined all of that? Your kind of whole genome is the entirety of that encyclopedia. Your chromosomes are those books, and your genes are those chapters. So just individual pieces of things that describe one part of your body or one job of your cells. Next slide, please, if possible. So let's start with what types of heart diseases can be inherited. Pretty much all of them. Heart failure is the biggest one we're thinking about today, those structural heart diseases, the things that make your heart weaker than we want it to be, the things that make it change shape. The biggest thing I hear about when I start asking people like kind of generic questions about their family history is, oh, my aunt has a weak heart, or my dad has an enlarged heart, or something like that. So those are all things to just make a mental note of. You can ask them more questions later, but just making notes of even those like little things that get dropped, again, around that dinner table, or when you go to the doctor with your mom because you know that your mom doesn't actually take her meds and you need help. We have the electricity disorders that someone mentioned already as well, like things like AFib can be inherited as well. Cholesterol disorders, so thinking about that fried chicken, not all of us can digest that and break that stuff down the same way as everybody else, and that can be inherited. And then finally, the aortic diseases. I know Dr. Sanders mentioned some of those like aneurysms, the like bulging in the heart. Those can be inherited too. And if you do one more click, please, because these can all be lifestyle based too. So just having those actual diseases doesn't mean that it's actually hereditary. Some of it's lifestyle, some of it's genetic, and some of it's a combination of both. So it's important for us to not only know your history, but also, again, why we ask about your family history. Next slide. November, like I said, is Family History Awareness Month. So I gave a couple examples of questions that you can ask around that dinner table next month. These are the ones that I ask everybody, and these are certainly not all encompassing, but I think they open up good conversations about things. So has anybody in the family been diagnosed with any kind of heart disease under the age, especially of 60, but I would even say under the age of 50, even more. Same thing with the ages, but anybody have a pacemaker put in less than 60? Or a defibrillator. We have implantable defibrillators now too, so thinking about those as well. Or like transplants, like Dr. Saraswat said, LVADs, all those things, especially, like I said, under the age of 60. Has anybody in the family died suddenly with like no explanation, where it was just like, went to bed one night, didn't wake up the next day, but they were totally healthy? That can be a sign of a hereditary heart disease. Has anyone in the family had a baby who died either at birth or shortly after, or has anybody in the family had a baby who died of quote unquote SIDS, or sudden infant death syndrome, where it's just kind of like, we don't know why your baby died, sorry? That is a huge red flag for a potential hereditary heart disease, and one that we hopefully will be able to start catching earlier and earlier the more we know about it. And then the last one is kind of a vague one on purpose, but just are there more than one person in the family that has this? I usually say a good number is 3, but I've certainly seen just 2 people. I've certainly seen just 1. So not having other people in the family is fine too, but that should certainly be a red flag as well. Next slide. So let's talk a little bit about why so many people in my family may have heart disease. A lot of these, like I said, are inherited, and they're inherited in what is fancily called autosomal dominant, which, going back to how we all have 2 sets of chromosomes, so we all have 2 sets of our genes. When we think about what's called autosomal dominant inheritance, it's that you only need one of those genes to not be functioning correctly for it to actually put you at risk to develop the disease. Which means that you, if you have one of these, have a 50% chance of passing on that defective copy to your children. That extends to your siblings as well, because your DNA is half of your siblings' DNA too. So even your siblings, think about your brothers and sisters, as well as your kids. And then just having, and I think Dr. Saraswat mentioned this as well, just having the genetic variant or just having a genetic disease identified does not formalize the diagnosis. Not everybody with the valine isoleucine mutation that Dr. Sarswat mentioned to us, will actually go on and develop amyloid. But it does let us know who we need to be looking at in the family. So it just helps us get a sense of who actually do we need to be spending that time with. And if you don't have that variant that's in the family, congrats. You get to go live your life and not worry about this. But if you do have it, that gives your doctors, that gives Dr. Sarswat the capability of being able to follow you and make sure that as soon as you develop anything, we are on you. And that gives me the opportunity to work on it with your kids as well, so that they don't have to get to that point too. Next slide. So let's talk about genetic testing, my favorite thing to talk about. So the who and the why of it, we always want to test someone first who's actually affected. So someone in the family that has disease. And the reason for that is twofold. The first is that if you don't have disease, I don't know what I'm testing you for. And the second is that if I test you and you don't have anything, but it's negative, I can't tell you for sure if it's not hereditary or if I just didn't look at the right things. So we always want to make sure that we're testing, in theory, the most severely affected, but anybody who is affected gives us the best chances of actually finding something that's useful that we can use for your family. And then the why of it all, because I think that also and we'll talk a little bit about some of the hesitations that people have, but the why is also equally as important as the who. So we heard Dr. Sarswat mention that there are treatments that depend on knowing your genetic status, especially with amyloid. There's treatments that are only available to people with the hereditary version of that disease. So if we don't know if you have the hereditary version, we may not be able to get you those treatments. So it'll change your management potentially. It can also confirm a diagnosis in some cases. Again, thinking more broadly about heart diseases, not just amyloid, but it does help confirm certain diagnoses. And then the big thing, my bread and butter, my favorite thing is this family screening, is getting to actually sit down with you, walk through your family history, to hear about your kids, to hear about your brothers and sisters and their journeys and their health and how can I better help them. And making sure that they don't have to get to the same spot that you're sitting in. A lot of times I'm seeing people too far in disease to do things, but I want to make sure that your kids don't do that too. Next slide. The big hesitations for everybody. Cost is always the biggest question, and I know Dr. Sarswat alluded to the fact that insurance is an issue and all of that. One of the benefits of working with someone like myself, who's a genetic counselor, is I get to spend a little extra time in clinic compared to someone who's as busy as Dr. Sarswat, who has a stacked clinic, walking you through payment. What does that look like? Who am I paying and what am I paying for? And is my insurance going to cover this? Or do I need to do this other thing first and all of that? So that's partially my job, is to help you navigate your health insurance, or lack thereof for that matter, and making sure that this is affordable and accessible to you, whether it's for amyloid, whether it's for heart failure, or whether it's for AFib or your cholesterol or whatever it may be. That is my job, is to help get you that testing at a price that is affordable for you, making sure that your insurance actually covers it if they offer that kind of thing. The second thing is discrimination and privacy concerns as well, but we'll talk about the discrimination laws first. Dr. Sarswat, I think, mentioned stuff about your health insurance. Please do not worry about your health insurance if you do genetic testing. They may or may not cover the testing, but they cannot use that testing to change your premiums. They cannot use that testing to say this is a pre-existing condition and now we're not covering any of this anymore. They cannot use that information to change your health insurance, and you will not lose your health insurance just because you went through genetic testing. The same thing goes with your employment. So for those of us who are still working, who don't have the privilege of being retired, your job cannot use your genetic information by itself to make hiring, firing, job placement decisions. There are some carve-outs for that, most of them due to safety concerns. So the big carve-outs are active duty military members. So for those of you who have kids who are in the military or are in the military yourselves, things to consider when we talk about genetic testing. And again, a genetic counselor like myself will walk you through those things as well. So active duty military, company, like really small companies less than 15 people actually don't have to follow these laws, unfortunately. And then like people who want to like fly planes commercially. The FAA does have regulations for that as well. But again, more safety related. If you are at risk for a sudden cardiac arrest because you have amyloid or any of these other things, they don't want you flying a jet with 700 people on board, which I think is a fair assumption to make. And then that's kind of all these laws cover. That's the big caveat with genetic testing, and especially testing for people who may not be affected, which is why it's good to start with someone who is affected. If you are unaffected and identified as having a genetic heart disease, your life insurance companies could potentially use that information and change your premiums. They can't go back and change anything once you have them in place. So go get that life insurance now while you're healthy and everything. But if you go to them and they ask for a health screen, they can ask about this kind of stuff. And if they ask about it, unless you want to commit perjury, you have to tell them about it. So just making sure that, and again, this is a conversation that I have in clinic every day of like, what do you have in place already? Are you comfortable with it? Do you think you're going to want more? Does it cover what you want it to cover now? If not, let's pause and come back to this. We can still start other treatments and whatever that may not like hinge on your genetic testing results and still get you those things that you think you need and want and deserve to have. Privacy is always the last one that people ask me about, especially given the times. I mean, we hear every single day about a new data breach, I feel like, and some of the, 23andMe's and the ancestries and all that don't escape that either. And honestly, the clinical labs can't necessarily escape that either, but they do have a lot higher safety in place at these clinical labs. So don't worry about the police calling you randomly saying, can we have your DNA because we think your uncle has committed some crime or whatever. That's not gonna happen with clinical grade genetic testing. Those 23andMe's, those ancestries, all that, they're super fun. I'm gonna be honest, I did one. I don't think anybody in my family's committed a crime, but who knows? I don't know. We'll see what happens in 10 years. But that data is now 23andMe's. It's not yours once you do that. So just making sure that we are taking those kinds of things with a grain of salt, that if we want to do the 23andMe's for funsies, if we want to do the ancestry because we want to find that long lost brother or sister or whatever, just making sure that we do fully know, A, who owns that data and what happens with it. In order to be, linked to the Golden State Killer or whatever, they had to go submit their DNA to a whole separate data bank. So just, if you want to do them, great, but don't do that part of it, So just making sure that if you are going to do some of those more like quote unquote direct to consumer tests, that you know what you're getting into. And we can talk more about this during the Q&A portion, because I'm sure there are more of those kinds of things as well. But let's kind of segue into what does this process look like? What does it entail? The genetic testing process itself is actually pretty easy. We're looking specifically at those heart-related genes, at least in this setting. There are genetic tests for other types of heart disease, kidney disease, cancers, all that kind of stuff. So certainly if as you start having those family history conversations, other things besides heart disease come up, definitely feel free to ask your doctors about that. We're looking specifically at the heart-related genes, and depending on your history, your providers, what labs they work with, all that, it can be done as easy as a simple blood draw, 1 tube of blood, or even just swabs or saliva samples, and then it just gets sent directly to the lab, and we get results like a week and a half, 2 weeks later, and go from there. Next slide. We'll finish everything up with kind of the like, how do I do this? I think we've talked a lot about having that good relationship with your primary care provider, and I think they are a great place to start. They know the most about what's going on in your community from a provider standpoint. So talking to your primary care provider, not about your history, because they hopefully have a good idea about that, but about your family history. Bring them something with just a couple things written down about your family history. You can ask your primary care provider for a referral to a genetic counselor, someone like myself. We are few and far between sometimes, though. So sometimes your doctor may not know how to find one. I've put 2 links up here that are really great places to start. The first is our National Society of Genetic Counselors, or NSGC. They do have a really nice, find a genetic counselor option. And you can put your zip code and check off whatever specialty you feel like you need. And then it'll generate a list of people and how to reach out to them. The other one that's more cardio specific is the Cardiogenomic Testing Alliance. They also have a Find a Genetic Counselor resource on their website, and that's cgta.com, which is fun because CG, and A are the actual DNA code, which is fun. And then the process, again, is just meeting with your doctor or meeting with someone like myself, getting that sample collected. Sometimes there's this whole big insurance thing where I have to ask your insurance, can I do this or not? And sometimes that takes time. And then we do the sample collection, it gets sent, results get back, they come to my inbox. I give you a call with those results, or you can come into clinic, whatever you want. We talk through everything and kind of make a plan from there. That is pretty much the process is easy, not super invasive, and it gives you valuable information. So I hope, if anything, I think that was my last slide, yes. I hope, if anything, you guys all go home and talk to your families, figure out how you want to get that data, figure out who you want to talk to, figure out who the person in your family is that knows everything, because every family has one of those, the one person that collects everything that says, Aunt so-and-so has this, and this, and all that kind of stuff. So just find that person, write it all down, and bring it to your doctor for your annual. And have a good Thanksgiving with your family, too. So, yeah.
Don't be. I'm going to like to bring back Dr. Sanders, come back up here. Dr. Sarswat, if you please come on back up also. And then, of course, our other panel members, Keith and Cheryl Haney, Giselle, and Jasmine. Go on back up here for us. Thank you. No, come on. Yeah. So at this point, first off, I'll remind everybody, there is part 2 to our discussion. It's going to happen tomorrow. So tell your friends if you enjoyed what we had here today, there's going to be a little more continuation of the discussion. Also, remember, if you filled out the pre-portion of the survey, I want you to fill out, that was the first part, please fill out the second part of the survey also. Also, I wish if you would all just take a moment to give a hand to Deacon White, who did a wonderful job as far as keeping the audio-visual things going. Thanks, Deacon. Not an easy task dealing with these people. I can assure you that he had to work with a lot of prima donnas. No, they're all very good. Just kind of, if you have a question, just raise your hand and I'll come to you. But if we can kind of start off a little bit, we talk about the genetics of ATTR, but would you please tell me, someone may have the genetic abnormalities, but what role does environment and or dietary factors play in the expression of the change in genetics? Natasha, if you want to start off first, and then, or either one of you, whichever one you want to start.
Is it on? Okay.
All right, you're on.
I think it's going. Okay. I think it's a really complicated question, and it's a really good question, and I think one that we're still kind of exploring. There is obviously dietary things and all that can kind of exacerbate everything. I wish we had one good test that could say oh, you have this genetic thing, but also your smoking didn't help. We don't really have that test. We know that there are different ways that your environment, that smoking and drinking and, all that kind of stuff, regulate the way that your genes kind of turn on and off. It's something called epigenetics. It's all about fancy methylations and all that kind of stuff. But I don't think we have a really good understanding about exactly what triggers some of those things, unfortunately.
Okay. Now, in the beginning, we talk about the unknown of who actually has this problem, or at least it seems that way until the disease manifests itself. So, Dr. Saraswat, give me a handle on the incidence of ATTR cardiomyopathy, and will we ever have a good idea on how frequent this disease is?
So we think when we look at the data now that ATTR cardiomyopathy is probably close to 10% of all heart failure. And heart failure in the world, and certainly in the United States, is an epidemic. It's rising and rising and rising. And as we all get older and the baby boomers get older, there's more and more heart failure. So this is a large number of people. We are not at the point that we're doing massive genetic screening of the population, right? So we don't know all of the different genetic abnormalities in everybody and how frequent this is. We think, again, like the mutation we were talking about is in 4% of African Americans, but that still may change. And as we learn about all of these different variants and we try to understand what percentage of people with the gene variant actually get the disease, that's changing as we speak. We're still learning. Genetic testing has become so much easier, and still, there are challenges, but so much easier than it was 10 years ago. But as we amass more and more data, we will hopefully figure some of that out. But again, we're still not at the point that we test every baby for a transthyretin mutation.
What about while you had the microphone? I want you and Dr. Sanders to answer this, because what age group are we starting to see ATTR?
Mm-hmm. So it depends on the different gene variant. There are certain gene variants, for instance, there's something called Val30Met that we see in people more European Portuguese that can come in the 20s, that can cause neuropathy in the 20s. Most people with the V122I, which tends to cause more heart problems, are not coming with symptoms usually until their 50s, 60s. I can't think of anybody who's really manifest symptoms earlier than that, and that's what's in the literature from what we know now.
Dr. Sanders, I seem to recall we get these glorified stories about athletes suddenly falling over with cardiac disease. Does this tend to be more of a young person's or older person's problem, or that you're seeing the beginnings of the problem when we're young?
Okay, I think that's, if I hear the question, it's about young athletes falling over with sudden death.
And we hear about that, but is heart problems really something that just starts in the young, or is it primarily an older person's disease?
Well, I think in that situation, many of those cases are due to hypertrophy of the aorta. And that starts very early in life and may not be picked up. So that's one type of heart disease. But I think also in many of those cases, if you have been attentive, there may have been symptoms, but for the most part, there are no major symptoms. But the larger portion of people with heart disease tend to be older, tend to be much older. I'd say starting somewhere around 50, going on into the remaining decade. So but you also have a whole group of very young children who are born with congenital heart diseases that may also relate to some of those young people who then have those sudden death events while doing exercise and activities. So I'd say it's kind of bimodal, if you will. You've got a large group that are older people. One of the risk factors for heart disease is aging, period. And you have the congenital or early things that appear in much younger people.
How many people here have a primary care physician? Raise your hand for me, please. Raise your hand. Primary care physician. All right. Good. When you go see your primary care physician, ma'am, how long do you spend with them? Good.
My doctor is very long-winded, so it's about an hour and a half.
You said long-winded, but are they long listening? No, they're listening to it. They're just talking to you. Talking. All right. There's just talking, she said. So the reason I asked this question, okay, great. Now you're telling me somebody comes in complaining of their hands feel numb, they're short of breath, their feet feel a little bad, I got this, that, and the other, and they're 35 years old. Am I going to sit down and really in that 15 minutes I have to see you, am I really going to spend time to talk about Well, tell me about your amyloid. All right, Dr. Sanders. What am I going to do in that 15 minutes?
But I am going to say this, though, that sometimes what you get in that 15 or that 20 minutes, many primary care physicians spend a lot of time thinking about their patients. And it may hit you in the middle of the night that this all fits together and I need to pick up the phone, I guess today, the cell phone or the internet, and give you a call back and let's have a longer conversation. So I don't want to minimize the importance of the dialogue between the patient and the primary care physician. And sometimes you may need to make sure that you bring somebody else into that room that knows that patient, just so they keep them honest. And I say that with all due respect, because one of the things I find about men, particularly, is that most of us are there to convince ourselves that there's nothing wrong. Am I off base?
Hey, this is not a male bashing time. No, we're not going to do that. All right, Jasmine, you're kind of pushy. No one, Jasmine. Jasmine, you're pushy. So you're sitting there and you're seeing me, and I'm sitting there going, okay, I got 15 minutes. I got to ask you about a couple of things. But you're not satisfied with how this conversation is going. What do you advise to your patients who ask you the question, wait a minute, this is what you can do. How do you get satisfaction? And how do you tell Cheryl Haney, this is how you get satisfaction out of your physician's visit?
Honestly, being honest.
Yeah.
Like you give details. It's more than just a headache. It's more than just a stomach ache. It's more than just these things. There are things that's happening when you're moving. There are things that's happening when you're sitting down. Be in tune with your body to where when you're sitting there with your doctor, they have a complete understanding. Be open, be honest. I am honest about the type of the frequency of the medication I take. That's another thing that we don't admit to when we're prescribed something. Yes, it's overwhelming.
This is what I want you to tell me though. No, you're sitting there and your doctor is long-winded and they're talking. How do you take control, if you will, of that conversation to say, no, I need you to hear me. That's what I want to know. What do you tell people how to do that?
I need you to understand what's going on with me. I need you to listen to what it is that I'm feeling with these symptoms that I'm experiencing. You 1,000% put out there how you're feeling with these experiences. You go on and you say to them, hey, this is what's happening. I know what you're saying right now, but this is what's in my day. Okay. This is what is happening, and this is what I need to have addressed. This is what matters to me.
Giselle, at what point do you sit down and say, this person is not doing what I want to get a second opinion? What do you do about that?
Well,
you can't quite reach, she don't want to talk to anybody right now. Dr. Sarswat she's out of the country.
okay.
So what do? You want to so how do you bring that up?
Well, I'm going to piggyback to your question with Jasmine.
Make sure you answer my question, this question.
I am. I walk in
I
with
want
a
you to
piece.
hear me now. See the way? It's not just doctors who do that. Yes, you do. Okay, go ahead.
I walk in with my list when I walk in that office. So when we're talking, I'm making sure we go over every point that I want to discuss
Say
with
that
her.
again for us, please. You do what? You come
Discuss every point
on a list.
with my list.
Gotcha.
Now, there are times that we get a little winded. If I don't get to those items, I'm going to send her a message on my chart. Either her or her staff will respond to me and let me know the answers to my questions.
Oh, I'm sorry. I can't have a life outside of my office?
Nope.
You mean you want me to answer your questions after? You hear that, Dr. Sarswat? How do you feel about that? She wants you to answer her questions It's 6 o'clock. You've done your day at work. We'll come back to those.
I got her cell phone number.
Yeah. I'm a little old school. I'm okay with it. My family knows that. My kids know it. I'm a little old school in that way. But I think, I mean, for us as, physicians, it's having the right team. I have a wonderful team of nurses and nurse practitioners that work with me closely, that know and love my patients the way that I do. And that helps support me if I'm running around, that they can answer a lot of those questions. They can corner me and say, Natasha, you didn't answer Giselle's questions. You better get back to her. And some of it is just a team.
Hold on a second. So you talked about a team. You talked about a team. Do you look for a team as far as taking care of things when you go to the doctor? Not only the team of all the Chicago cops and everything that were here. By the way, y'all should get a speeding ticket for as fast as you went driving through here, but that's all right. We're not going to tell anybody about that. So do you look for a team of doctors who are going to take care? If you say, hey, is it just that one person, or you look for the all-encompassing team to take care of it?
Well, coming from 0 to 100, because I had never been sick, answering questions, this one right here, ask a whole lot of questions, but going from 0 to 100, because I'd never been sick. But then after being diagnosed with this disease, and then I had to start taking medication. So then we had to really start asking a lot of important questions, because I had never taken medication before. But then in the process of taking medication, I came up with these symptoms that I never experienced in my life, like lightheaded, dizziness and stuff like that. So they had to go through with each one of the medications that they prescribed to me and start cutting it back, because I felt sicker. I felt sick, So my support team, which is right here, had to ask a lot of questions.
Okay, all right. Now I want you to tell me about your medical support team. Go ahead.
It is absolutely important to have a medical support team. While he had amyloidosis and he had the heart attack, his primary care doctor is good, but he also has a cardiologist. He has several doctors that he goes to see, because you want to go to see the doctor that's going to be able to address the concern. If I'm having heart palpitations, I'm not going to go to my gynecologist. I'm going to go to see the doctor that's their specialty. So we did, he does have a team of doctors, and it's important to have a doctor who focuses on that particular issue.
I guarantee you, he's not going to go see your gynecologist either. Go ahead, Giselle. You were telling us about I want to know about that second opinion. How do you go about getting that second opinion?
I email my cardiologist and ask her, who should I see? Mm-hmm. I have a connection with her, and real talk, if I need to see another specialist, I will email her and her team and ask them if she has a connection with a neurologist or gynecologist or someone. So I know that there's a connection that she can communicate with them. Second opinion, I'm going to the second top hospital in the city of Chicago and make sure they are a specialist in that, whatever I'm going to see them about.
So we naturally assume that University of Chicago is the top one. You see the way she snuck that in there? I like that. All right, how many of you people eat fried chicken? All right, keep the hands up. How many of you eat fried chicken once a week? How many? Okay. All right. You see that? We got some patience for you, Dr. Sanders. All right. Now, please, there is no relationship between Dr. Lawrence Sanders and the Colonel from Kentucky. May sound the same, but it's not. So I joke. How much time, I want to go through each one of you. How much time do you spend with your physician, or is the physician talking to the patient about diet? Go ahead. You start there. You get the microphone. Go ahead.
That one.
Talk to the microphone. It's on.
Okay. That one is very important. So this was, I give it 2013 when I began to have other neurological issues within my body. What I looked at was first what was in my freezer and what was in my refrigerator and what was on my shelves. When I say that I had to get rid of things that I was eating I did that. Did my family agree with it? No. But when I say still to this day that there are things that we refuse to eat, and that isn't thanks to my sister, because we began to look at, hey, all honey is not honey, all syrup is not syrup. And some of the foods, the frozen foods that's out there, what's available to us, it's not always the greatest. And I know we live like this high, fast-paced life and things like that, but I kid you not, nothing is more important than talking about your diet. And that part I do with my primary care physician, because here he is someone who is anti-medicine. He is. That it is hard
We can't have
to
that.
find a doctor that does not only depend on medicine. There is a part that he has to say,
All right,
hey,
Cheryl.
you got to do.
I know he has no, so far I haven't felt that he did anything except for have all the heart trouble. So you did do something else in this, I guess. But anyway, so what does his plate look like now?
Well, it looks the same as it did before.
Okay.
Because I come from a really heavy family.
Mhm.
So I wanted to make sure that some of the symptoms that I've seen in my family,
Yeah.
I did not want to experience. So we've always been pretty good eaters. And like you said, he ran 5 miles a day. But I think the one thing that we don't look at our sodium intake, because that plays a great part in our diet. You know, so even if we're eating fruits and vegetables all day, but if you're loading it with butter or salt, then that changes the dynamic of it.
Okay. Rachel, you told me all that wonderful genetic stuff, but the genetics are this man is going to have 2 dinners of fried chicken a week. So he's got a lot of chicken written on his genes. How do you make that mesh to a health?
I personally don't. That's out of my scope. But I can refer you to a dietitian to help.
Yeah, all right. Dr. Sarswad, come on. That was lame. So you still think that University of Chicago was still number one? Talking about, see the way she dodged that? Okay, go ahead. Tell me about what you told your patients about.
No, I think I wish that we had more time in clinic, right? That's the short answer. We talk about diet, it's a 2-minute thing, and it should be longer. And we acknowledge that we wish we had more time to talk about it, but there are so many things to cover in that little bit of time that we don't do a good job of it. One of the things that I find helpful is often asking patients, what did you eat yesterday? Because I feel like that keeps them honest, right? They might say, oh, I eat healthy all the time. I eat salads and I do all of this stuff. I'm like, okay, tell me what you ate yesterday. Breakfast, lunch, and dinner, go. And then you hear the real truth. And that's quick and that's easy and it gives me a snapshot into their life.
You want another fun thing? People tell you, oh yeah, I eat salads every day. Ask them what they put on the salad. Oh, that's fun. Dr. Sanders, come back to you.
I think one of the things that I found very helpful is to help people create a realistic pathway for their diet. What I often try to say to people is, look, we're all human. If you keep to this diet 95% of the time, I'm okay. If you slip 5% of the time, we can deal with that.
Mm-hmm.
But now, if you're keeping to the diet 5% of the time, the 3 days before you come to see me, and the rest of the time you're off the diet, we got a problem. And we got to figure out what to do about that. And that seems to get folks' attention and opens the dialogue in a way that begins to help people. And I just want to pick up on one thing now. I said the more color on your plate is important. I'll talk about green beans this time. If you put a piece of ham hock in those green beans, they turn dark and they essentially become a fried food. Whereas if you try to stay away from meat in vegetables, and I grew up in the South, so that's a normal part of the whole diet. And so it's a really difficult thing to change, as is the amount of salt that we eat. And, it's the way you learn how you like salt is your mother tastes the food, she puts a little bit more salt, and that's how you learn. And so I think some of those things can look genetic when actually they're family habits. And I think you made a good point of that.
She dodged that part of my question, by the way. Now, I want you panel members to think about what you want as your one take-home message for all of us to have. We're going to start at this end. But while they're thinking, we're going to give them a chance to think. Think of like this Jeopardy. Somebody knows the Jeopardy music. Go ahead and start playing it right now. I want to remind everybody, tomorrow is part 2, and we're going to continue this discussion. But I also want you to know, because this man does so many wonderful things here at JLM, it's nice to have something named after you, isn't it? Anyway, what he does here, he is also going to provide gift certificates or gift coupons when you come back here tomorrow. Now, you got to be here tomorrow to do that. We'll get you in a minute. We'll get you in 1 second. So please remember, come back tomorrow, and then you see him. Yes, sir, you had a question. The question was, do you need to register again? No, you just show up here tomorrow, right? Bring somebody with them? Oh, I said bring somebody with you, and that's all you need to do. So that's great. All right, but before we get to them, how many of y'all have greens? You know, kale, collards, things like that. All right, raise your hand. She's trying to be slick. She put her hand down low. Okay, when y'all cook this stuff, what does it look like when you finish cooking it? Look like what? Is it still green, or is it starting to turn a dark green or kind of a brown color? And what do? You pour this juice and everything down the drain, don't you? To join Dr. Sanders' chicken fat down in there. Don't overcook your greens, folks. These things aren't supposed to be dead when you eat them. They're vital. We want to have something good with all this. All right. You eat greens, Dr. Sanders? Oh, see, she doesn't even do it, man. All right, we got to get you going. All right. What's the one take-home point you want us to have?
Know your family health history. Don't just talk about education and your kids and Christmas at your next family gathering. Talk about your health history, because we might have a lot of things that are hereditary that we need to find out about before we get the symptoms.
And one of those old boyfriends may show up at your door. Dr. Salzo, please.
The take-home message, I would say, is advocate for yourself. Speak up, make sure that you're heard, make sure that people are listening, and make sure that you know yourself and that you're going after the knowledge and not waiting until something bad happens. Advocate for yourself.
Rachel.
Well, Giselle took mine, but mine is probably just ask the questions. Whether it's asking the questions of your family history, so asking your parents, asking your brothers and sisters, asking your kids, but also know that you can ask the questions at your primary care or at your or at whatever doctor you're seeing. No question is a dumb question with your doctor.
Larry.
I think diet is important. Look at what you're eating, but don't only do it for you, do it for your children, your grandchildren, and even the next generation.
Jasmine.
Listen to your body. Listen to how you're feeling. Say something about it. Don't ignore it. Don't feel like, oh, it's going to go away, or that you are just as important to say something. Speak up about how you're feeling when you're feeling it. Don't ignore you so no one else does. And if you feel like they are, you speak up, just like Dr. Sarswat was saying. Advocate for you, and know that you matter at home and when you walk through those doors at any medical facility.
Cheryl.
My takeaway would be see your doctor regularly.
I'm going to tell you what his is going to be. Listen to Cheryl. But go ahead, Keith. What you have to tell me?
My take-home message is going to be honest with your body. Treat your body like a temple. Be honest with the symptoms that come across, and always be inquisitive. If something comes across that you may think is minor, treat it as a major, as major.
Ladies and gentlemen, please give, we're going to hold your question after. Give a hand to the panel, please. Please, again, fill out the surveys after the fact. We'll be around to take your questions, sir. We're going to bring up Reverend Miller again, but just remember, I want you to remember one thing. There's dinner after this, and the only thing standing between us and dinner is Reverend Miller.
Come on, Dr. Wayne Tusker. Let's give him a big hand. Our moderator kept us going, kept everything moving, and we're so appreciative. Yes, dinner downstairs, and I just looked at it. It's healthy, ready, and we'll be going down some of your questions and some communication, some networking you can do around the dinner table. We're so excited and looking forward to tomorrow being even a greater day. People are off work, and we're going to put out another call tonight to make sure more of our pastors and our friends get here to participate on tomorrow. We're thankful. That's my older brother, Dr. James Miller. And so everybody didn't have a doctor in the family. You know, my wife just called him anytime. I'm like, baby, he got more patience than you know. But having a doctor in the family does make a difference. So we've been blessed. And then when I hear, you know, all this stuff about what you shouldn't eat, I not only built the center, but right across the parking lot, we start growing our own chickens and got our own turkeys and our goats, and we want to eat healthy. So we, you know, we from Mississippi, so we just came up here and just brought in and make our own stuff. And so if you go across there, you see some turkeys or chicken around your car, they know how to go home when the sun go down. They're going to go right back in there and be at ease. So thank y'all so much. We're going to bless the food. And so when you go downstairs, you can just fellowship one with the other. Hasn't it been some good information and good opportunity? Give yourselves a hand. We are blessed. I hope everybody's signed in, and give the team back there. Thank y'all so much. I'm just honored that we got in touch with each other and making this to move. God, we thank you again for this day and what you have allowed us to receive. Bless now and move by your power. Touch those who did not make it today, and they'll come be a part even on tomorrow. We're blessed and we give you glory. Bless the food and fellowship that will continue even now in Jesus' name. Everybody said amen. If you need to go to the elevator back way, and then there's some step. If you want to get down quickly, go to my left and go down. If you can walk, go down those steps. But if you need elevator or extra steps, go to the back and go down. All of them going to put us in the